The stage is yours, sir.
I would like to thank you, BOC team, for giving me the opportunity over here, and all the dignities and the students who are presenting here. So today I'll talk about some different topic, that is Neuro Optometry a little bit. Okay. So the topic is the traumatic brain injury. So so what exactly you understood by traumatic brain injury? Traumatic brain injury, it's not only the any type of accidents. So I'll start with one simple story or some small story. Let's say if some road accident is happened, and the brain is affected. So what generally we do that we emergency we is admitted to hospitals and stitches, all this activity we do that. Okay, and after that, after maybe 2-3 days or few days, we just discharge the patient, and patient is on to home. And now the patient complaint is started. Now what complaint? Patient is getting headache, patient is getting patient can get double vision, patient can get a lot of photophobia. So when this type of problem is starting, then as a optometrist, or I'll call as a neuro optometrist, you have a huge role to manage. So not only the traumatic brain injury. So what exactly is neuro optometry is different from the the optometry. See, there is nothing difference. If you do all this workup, like you have to, like if you consider like vision and visual acuity in differently, then you will understand what exactly different examination you have to do. Like if you say like vision, so vision not only the visual acuity, what we do generally like in clinic or hospitals, we see like how much we can see, that exactly you are measuring, like how much we can see, right? But when you talk about the vision, so vision is started from visual acuity and visual efficacy and the visual information process. As you know, the eye is only the two camera. They are just capturing the image, and this image going to our cortex, they are analyzing, and then we are interacting, right? Or you can say in between there is a lot of process is there. What is the process? Like as I told you, the visual efficacy. In the efficacy means what? Like how your visual system is efficient to deliver your properly vision, right? So what is including that? That is including accommodation, vergence, and eye movement. In the eye movement, cyclic eye movement pursuit. So this all things is called the visual efficacy. The next and most important part, which generally we don't measure it, that is called visual information process. What is visual information process? Visual information process means when that image is going to a brain, there is a lot of step is there. You can start from bilateral integration, like the coordination between left and right hemisphere. Along with that, laterality, directionality, which one is right hand, which one is left hand. Along with that, visual analyzing skill. In the visual analyzing skill, we have a visual perception. In the visual perception, there are a lot of component is there, and visuomotor integration, visual auditory integration. So and lastly, you have to see the intersensory integration. If you check all these things, then you can tell the patient vision is perfect. But generally, we don't see all these things. So neuro optometry means you have to see all these things, and you have to come up with a conclusion. So what are the patient, we can diagnose like any type of traumatic brain injury, any type of concussion is happened, any type of anoxia, dementia, stroke also are traumatic brain injury. Remember these things. A lot of patients after stroke, they have a lot of difficulty. What type of difficulty? They cannot balance it. They cannot walk properly. They cannot climb the stair. So this type of difficulty when is happening, you have to see all these things. And cerebral palsy, multiple sclerosis. So this all of the neurological disorder where you have a very important role to manage. The most important thing, if you thinking about you are the optometrist, you are the only the person, or you can professionals. No, you require a team. So what is the team? So team require maybe occupational therapist is required, maybe physical therapist is required, maybe psychologist, psychiatric, maybe special educator. So when you are working on this type of cases, you need a team, maybe dietitian. So all this entire team is required. So if you talk about the examination part, what are the element of the neuro examination? You have to see, as I told you, vision. You have to see the vestibular system, which is very, very important. You have to see the balance, you have to see the gait, you have to see the cognition, and how the patient reaction is there. So you have to check all this element, then you can conclude anything. So the 70% of brain is delegated to our vision, and 80% of the information through this world that is come through our eyes. And this all are the research things. Research have shown that in case of any type of traumatic brain injury, 90% they have oculomotor dysfunction is there, and more than 30% patient or 40 to 45% patient TBI, they have grade 3 you can say oculomotor dysfunction is there. So exactly what is happening in traumatic brain injury? So in normal patient, you can see everything, your balance is okay, you can think properly, your analysis is properly, your cognition is properly. Once any type of traumatic brain injury, it can be stroke, it can be any type of trauma, it can be a psychological trauma also. That is also a traumatic brain injury. So our CNS system, normal balance is breakdown. So what exactly happened? Our ambient vision, as I told you, the vision have again two pathway, right? One is the central pathway, one is the peripheral pathway. The central pathway is only to see how much we can see, like how many fingers that you say 5. So that's it. That is only for the central vision work. But whereas the peripheral pathway, we can say where pathway, we can say our ambient vision, which is very, very important for your day-to-day activity, for your driving, for your sport activity, even when you are working in the night condition. So all this time, your spatial orientation, your organization, that all things do by the ambient vision, and which is very important, we don't check that. So this is the neural highway of a normal patient, and if any type of neural highway means the connection in the brain, right? And after traumatic brain injury, the connection is become look like that. So you have to understand what exactly happening in the patient brain. So you have to be multimodal. You have to see the multiple things. As I told you, you have to see the central vision, peripheral vision, and along with the corneocellular pathway also. The 306 visual connection in 47 area of the brain is involved, and 25 are exclusively engaged in the visual acuity, and 7 are associated with the visual vision. Not only visual acuity, vision, right? You see the 1 million ganglion cells that traveling, like who are the taking the the image, or you can say sensation to our brain, whereas only 35 cells for the auditory system. So you just try to understand like how is important in the vision for a particular patient. So any type of we say is a neurological insult. We don't say traumatic brain injury or all these things we can consider as a neurological insult. If any type of neurological insult is happen in the brain, so you can see the third nerve palsy or sixth nerve palsy or fourth nerve palsy, sometimes diplopia, blurring of vision, and this is the most common things, and visual field defect. So as I told you, the vision is multimodal. 3 pathways is there: parvocellular, macrocellular, and corneocellular. The first 2 is very, very important. The third one is the corneocellular. That is, they are doing the balancing between your parvo and macrocellular pathway. So as I told you, central pathway, that is only to see how much you can see, visual acuity. High deficiency, high resolution visual acuity that is happening, that is only for the central pathway. Whereas peripheral pathway, as I told you, is for your posture, your orientation, your movement, your everything, that is your driving, your sport activity, whatever you are doing, that the macrocellular pathway, where pathway, ambient vision, that's all named as the same, that is responsible. Whereas corneocellular, as I told you, they are just balancing, and they sometimes help in your contrast. So now, if any type of traumatic brain injury is happening, what exactly the 5 things you have to see very quickly, and you have to see thoroughly also. So what are the 5 things? First, we say that is called any type of post-traumatic vision syndrome is there or not. That is called post-trauma vision syndrome. Then egocentric localization. We have a midline over here, imaginary midline over here. If you move this side, what will happen? The gravity will try to pull it, right? After any type of traumatic brain injury, that midline is shifted. Maybe this side, maybe anteriorly or maybe posteriorly. A lot of patients. That's why you see after stroke, you see the patient are not able to balance properly because the midline is shifted. And as a optometrist, the simple one yoke prism can change that patient life. You can reshift to the visual midline in the center area. And the third, you have to see the visual field defect, and obviously the perceptual defect also very important, and oculomotor defect. You look at NPC rather than the visual acuity first. What I told you, okay, visual acuity is not important here rather than the NPC. So these are the common sign and symptom for the post-traumatic vision syndrome. Maybe patient will get exotropia, double vision, blurring of vision, field loss, that can be happening. So exactly what happening in the post-traumatic brain vision syndrome? After any traumatic brain injury, the patient is become very much centric. They are very much focalized. Focalized means what? Like when the patient is reading, we read comfortably, right? If you are focusing more, so what will happen? You cannot focus for the longer time, and you will get difficulty. Maybe you will get strain, right? So after traumatic brain injury or any type of neurological insult in the brain, the patient is become very much focalized. So that's why they have difficulty to read. They have difficulty to concentrate. So that you have to change. You just think about the, when you are, visiting to any type of grocery shop, supermarket, or any type, cafeteria. Sometimes I think everybody will feel that, when you are in stress condition, you are thinking something, and you are doing shopping also, right? Some item is nearby you only, but you are not finding it, right? Agree? Yes. So that condition exactly happen after any type of traumatic brain injury. So they are, they are very much focalized. They are not able to see the whole things. So they are all the time they are in stress. Now second point, as I told you, the visual midline. So visual midline is shifting is happening. So what will happen? The judgment of that particular patient will dishamper, right? If your midline is shifted this side, so you will pull like that. The gravity is that gravity try to pull. So your exact orientation or spatial judgment will affect it. So this is the visual midline shift. The first one is the normal response. You can see this is the shifted to right. This is or it can be a left and shifted to midline to the left. Anteriorly and posteriorly also can happen. Right. So treatment is a huge things you have to see along with that, but we don't have time, so we have to basic. First and most important, you have to see if any type of diplopia is there. So first you have to manage the diplopia. And the yoke prism how many you know the yoke prism? Heard about the yoke prism? How many? See, how is the difference between normal prism and yoke prism? You heard about only base in, base out, base up and base down, right? Yoke prism, both the prism base will be on the same direction. Like base left, base right, base up and base down. Okay, so that is called a yoke prism. What the function of the yoke prism? Yoke prism actually work on the posture. So if your posture is changes, your midline is shifted, so you can change. And obviously, if any type of field defect is there, you can use different type of prism, and you can manage the field defect also. Now next is that is called perceptual defect. So what is the perceptual defect? Like because of the perceptual defect, if after traumatic brain injury, if any type of perceptual defect is happening, so what will happen exactly? The patient will not concentrate on anything. Patient concentration, like you are neglecting many things. Like you are reading, you are doing your activity, but you are neglecting many things. Maybe you are reading, but you are not understanding, right? So that is a perceptual defect. So for perceptual defect, you have to see a lot of perceptual things, visual perception you have to see, and then you have to decide. So very, very important, field is not just loss. Any type of after traumatic brain injury, if you do the perimetry and all this field test, you will get a field defect, but that field defect may be or may not just lost. You have to wait. Maybe it's suppressed. Why it's suppressed? Because if midline is shifted, either this side or this side or this side, so your field will be suppressed. So very carefully, first you have to see with the yoke prism, and you have to see like exactly what we are thinking the field is lost, exactly is that or not, right? So for that, what you do, the another idea is that you can put a binasal occlusion. I'll show you the picture of the binasal occlusion. That also works fantastic. The simple occlusion, you can put a 45 degree in the two eye, the limbal area, both eye, and you see the patient is becoming straight or not. So therapy, again, yoke prism is very important. Along with that, lot of therapy is there that is not possible to say here. Fifth point, that is called the oculomotor defect. So oculomotor defect, what you have to see, we called as a eye movement. In the eye movement, we have a saccadic eye movement, pursuit, and the fixation. So all 3 points you have to see properly. Okay, how is the patient fixation? How is the saccadic eye movement? For that, you have a lot of tests is there. You can do a DM, you can do a King-David test, you can do a dynamic visualizer. You see with all these things, and then you decide, okay, where is the problem, and you can manage as per that. Now, along with that, we have to see other things also. What are the other things? So first, that is called basic vision examination. First, we have to see basic vision examination. Then you have to see oculomotor based problem, non-oculomotor based problem, and also you have to see the non-visual problem. So what are that? So first, the basic examination. You see refraction, you see binocular status, ocular status. You have to see all these things. Then you have to see the oculomotor based problem like version or maybe divergence or accommodation. You have to see. Then you have to see non-oculomotor based problem. What I already told, like midline shifted, or maybe patient have a photophobia, or maybe patient have a motion sensitivity, or maybe vestibular problem is there. So that you have to manage. And third, you have to also see, or you have to take help from the other professionals, like from if patient have depressed, fatigue is there, or maybe you have to give proper diet, or maybe cognitive behavioral therapy is required. So all these things, the teamwork, you have to work a teamwork, right? So maybe you have to refer to other professional, or maybe you have to call to a clinic or a hospital wherever you are working, and you see what is the problem and just analyze that. Now, when you talk about the therapy, so before therapy, always we have to think about the 3 things, right? What is the coach CB? You have to remember the coach CB. What are the coach CB? You have to think about the cognition. See, first think about the cognition, then ocular. Any type of affective disorder is there, any type of cervical problem is there, then headache, cardiovascular problem, or any type of vestibular problem. You don't have to see all these things. As I told you, you are the part of that particular team, right? So you have enough brain. You have to just you have to pursue it, right? You have to train the brain properly, rewire the brain in the properly. So these are the visual issue where you can give a quick solution, but you have to wait for at least 1 to 3 weeks before the prescribing. If patient is getting double vision, you can give a binasal occlusion, or you can give a prism. You can give for light sensitivity, you can give a tint. Generally, we prefer 15% blue. If any type of vestibular problem is there, so definitely the vision training is the very, very important, right? And if any type of, as I told you, if patient is very much focalized, like you remember, after post-traumatic vision syndrome, what is that? Patient is focalized in particular area. So what you have to do? Simple plus prescription, patient make them benefit. Simple plus 0.5 prescription or 0.75 prescription can make them benefit. Then in any type of focal visual problem is there, so maybe sometime you have to prescribe prism. Your prism always not more than, you cannot prescribe 2 to 3. You have to prescribe very minimum. But you can give them training, like you can call for their office therapy and you can give them therapy for training purpose, right? So as I told you, the binasal occlusion, along with traumatic brain injury, there is a lot of other cases is there where the binasal occlusion is work fantastic, even including strabismus also. So why you are prescribing the lenses? What is your goal? See, simple. We are thinking only we are prescribing for the refraction. No, here the prescription is increasing the visual thinking, visuomotor things, the gait, your information, the entire pathway is changing. You are prescribing plus 0.5 only, right? But you are working in different manner. So along with that, The syntonic light therapy also are very important, like it's work fantastic for the traumatic brain injury and other cases also. Visual rehabilitation also require. So yoke prism, as I told you, it's to just change your visual midline. So you can prescribe base down, base up, base right and base left. And always we have to prescribe low passes to break the focal binding and prisms. Right? So how is working? The patient is becoming more peripheric. The patient is centric and you are prescribing plus points, so patient is becoming more peripheric. So I'll recommend if anyone want to read more, so you can go through these two books. These books are very important. Thank you. Anyone have any query? You can ask me. No? Yes. Can you please?
Post CB. I want to know what post CB is explained. I cannot.
Acha, okay. Post CB means, see, you have to, means when you doing a therapy, so you are the part of that team, right? So you have to think all these parameters. You have to think about the coordination. You have to think about the ocular things. You have to see any type of other problem is associated with that, or any type of cervical problem. Means what I'm trying to tell you, you have to think about the team, right? You cannot work alone. So whenever you require any help, you may call your in your clinic, or may you refer to the other professional. So it's a teamwork, right? Anyone have any other query? Yeah, please. Little bit louder, please. Yeah. Okay, it's a very good question. Actually, she is asking like, if someone is centric, I'm centric. So centric means what? You are over focalized to any particular things, right? If you are doing a reading or whatever activity you are doing, right? Right now I'm doing a computer, so I am over focalized in particular area. So that glasses is not for the refraction. That glasses you have to prescribe for the any type of near activity. So what exactly happened? Where you are focalized, so plus lenses will make him peripheric. So more peripheral information patient will get. Now why you are like the example of the grocery or stationery, when you are visiting to any grocery shop or any supermarket, because of centric, you are not able to see the whole things. Okay, so that's why what happening, if you are not finding anything, so you get a anxiety, and that will create a stress, right? So what exactly we are doing here, we are just make them peripheric to see whole things. Okay? No, here again I'm saying, see, as I told you, like the prescription not for the refraction or relaxing things. One, if you see these things, the one simple lenses, how you can change all these things. This all are the behavioral things of the person, like how the lenses, glass lenses is changing the patient's behavior. I know this is a huge topic. It's very difficult to say in 10-15 minutes. Anyone have any other query? Yeah, please. Okay, I'll tell you. There is a three pathway is there: parvocellular, magnocellular, and coniocellular. Okay. What we see? Acha, you want to see the slide? Okay, so like central pathway, again I'm explaining like little bit. What we do generally in our practice, what do you see? Okay, how much like visual acuity measure, right? 6/6 or 6/12, 6/9. So that is only the central pathway. You are only measuring the central pathway. That is only 5% of vision. That is not vision, that is the visual acuity. But when you talk about the vision, you have to see from here to here, right? In between, what are the processes happening? The eye as a camera is capturing the image. That image is changing to electrical signal, and that is going to a brain. different area is there for analyzing. Someone is analyzing your things color, someone is brightness, someone is either the object is dynamic condition or static condition. So brain is analyzing and then you are reacting. So in between processes, so entire things is called the vision. Second, visual efficacy. Efficacy means either your lens is working proper or not, your muscle is working proper or not, your eye movement is working proper or not. And the third, that is called visual information process. So in visual information process, there is a whole lot of things is there, like bilateral integration. We have a two hemisphere of the brain, two hemisphere coordination, that is called bilateral integration. Right direction, laterality and directionality. Which direction you are, you are stretching my hand. So that called the laterality and directionality. Then visual analyzing skill. In the visual analyzing skill, we have a visual perception, like how we are perceiving, how we are seeing. Like if I draw a square or circle in this background, that background, or maybe different background, will you be able to recognize that particular circle or square in different background or not? So there is a lot. Then your visuomotor integration means eye-hand coordination, eye-foot coordination. Visual auditory integration. You just think about that. The same lectures, if I deliver in the online, you will not understand better, right? Everybody face that during online lectures, So there is a difference. So means you require a auditory, you require a visual, right? So and last, that is called the intersensory integration. What is intersensory integration? All the senses you have to do. Like you are giving some activity where tactile is working, visually you are seeing, auditory is coming. So all this activity you have to do. That is called intersensory, right? Any other inquiry? Okay.